This class will discuss the dynamics of disease transmission, the principles of outbreak investigation, and measures of risk used in epidemiology. When you're investigating an outbreak, the three most important variables to consider are the time of exposure, the time of disease onset, and the incubation period. First, you need to define the outbreak and examine the distribution of cases by time, place, and person. You have to establish a case definition, and you often need to interview people with the infection to determine what symptoms and other factors they have in common. Early on, it's important to make sure that an outbreak is actually occurring. The World Health Organization and other public health agencies have definitions for what constitutes an outbreak of a specific disease, which can vary based on the context, such as whether the disease is endemic in the country you're working in. As an example, here's the World Health Organization's definition of a suspected cholera outbreak. It's interesting that the definition of a cholera outbreak can be met with a single case, but for many diseases, at least 3 cases are needed to meet the definition. For another example, this is the Alaska section of Epidemiology's definition of a pertussis outbreak. Pertussis, also known as whooping cough, is the P in the Tdap vaccine, which protects against tetanus, diphtheria, and pertussis. Pertussis is a bacterial infection transmitted via aerosolized droplets or contact with respiratory secretions. The incubation period is usually 7 to 10 days, and it causes a severe cough with a narrowing of the airway, which causes the whooping sound, and people may cough until they vomit or turn blue. Pertussis can be fatal, and outbreaks have become more common in the past couple decades. It's considered endemic in the US. Laboratory tests are certainly very helpful for identifying the cause, but there can be delays, and in some settings, lab results may not be readily available. Your case definition should be as inclusive as possible, but you don't want to catch totally unrelated cases if you make it too broad. Once you've figured out the cause, you would either recommend or implement control measures, depending on your role, and communicate findings to anyone who needs to know. Depending on your role and location, you might be working closely with a city, county, or state health department or a tribal health organization. But if a public health agency isn't involved throughout the process, you certainly need to notify them and communicate the findings once you've identified the outbreak. Just like with chronic diseases, in an outbreak of an acute illness, only a portion of the people who are sick will seek medical care. There are likely more cases in the community that won't get a formal diagnosis or laboratory test result. Because of this, laboratory confirmed cases of any illness are usually an undercount of cases in the population. Here's an example of investigating a foodborne illness. You just started a new position as the student health director for Kodiak College, which has 1,000 students. On May 6th, you have several students come in with acute GI symptoms and jaundice. You get a thorough history from each student and find that the 3 students ate at El Chicano the night before. As more ill students arrive, you construct a table to track exposures. You call the restaurant manager and are able to get a record of charges associated with student ID card numbers to get an itemized receipt for all 150 students served since yesterday. You work into the evening and coordinate with the local hospital due to the volume of cases. You have 60 ill students by the end of the night, 56 of whom ate a burrito. To investigate this outbreak, you're going to consider the time of exposure, time of symptom onset, what symptoms, and the incubation period. For this example, we know that 56 students total are ill, and because 150 burritos were served since yesterday, we can subtract to know that 94 students are well. In a situation where you have many exposures, represented here by burrito ingredients, it can be really helpful to make a table, and then you can calculate attack rate for each of the different exposures to get an idea of what was the most likely exposure that's causing the illness. Attack rate is a proportion calculated by dividing the people with the exposure who got sick by the total people with that exposure. You add the people who were exposed to each food who are ill to the people who are exposed to that food who are well to get the total people with that exposure, which will be the denominator for your attack rate. Then you divide the people with the exposure who are ill by the total people with that exposure to fill in the attack rate column. In a real foodborne illness outbreak, it's never clear cut where all the people who ate the infected food are ill and all the people who didn't eat that food are well. There's always noise in the data. It could be that people shared condiments or touched a contaminated surface while passing shared food items or platters, or maybe people touched hands at the meal, or utensils could have spread the pathogen into other food. So, as much as this is a silly practice problem, it's somewhat realistic in the sense that you would never have one exposure with a high attack rate and all the other exposures with an attack rate of 0. Cross-tabulation is a way of looking at overlapping exposures. You can also use this method to make a table of symptoms and exposure with onset. To format that type of table, you would put case number on the left column with onset, symptoms, and exposures horizontally. For each food item, we add those who are well who ate the food to those who are ill who ate the food to get the total people who ate that food item. So for rice, we add 51 to 56 to get 107, and we divide 51 by 107 to get an attack rate of 48%. We can do the same thing to get the attack rate for people who were not exposed to each food item by dividing the people who are ill who did not eat that food by the total people, adding them together to get the attack rate for people who did not have that exposure. Remember that a proportion always has to have all the people that are in the numerator in the denominator also. That can be a helpful way to remember that you need to add the ill people and the people who are well for each exposure together to get the denominator, because it's the people with that exposure who are sick out of the total people with that exposure. Attack rate is similar to incidence rate, but it's not exactly the same because it's a proportion rather than a rate, and time isn't actually in the denominator. Attack rate is used for an outbreak investigation of an acute illness, and the convention is for attack rate to refer to cases that occurred during the time frame of that particular outbreak. So it could be over a week or over a couple months, depending on the outbreak. On the y-axis, we have cases. On the x-axis, we have onset of illness. In this fictional one, it's displayed with time in hours, but it's often in days. Epi curves provide key information about the outbreak. They show the magnitude and time trend, such as how quickly it's growing and whether it's ongoing, and can help you determine the cause. Outliers could represent the index case if you have an outlier way over to the left, or secondary spread following the initial outbreak if you get a second spike over to the right in time. If people become ill immediately after a foodborne exposure, that's often due to a toxin that's produced by bacteria such as staph, while a delay of 6 hours or more indicates an infectious agent such as salmonella. To define this outbreak, we would specify how many students are involved and interview each of them about dietary restrictions or habits and who lives with whom to determine if household transmission might be occurring. We would come up with a case definition, such as abdominal pain, jaundice, fever, nausea, and vomiting in a student or person associated with campus, and we would specify the time frame and the location. In our work to identify the causative agent, we notice that this case definition is similar to acute hepatitis. So we test the students for hepatitis A and hepatitis E, which both can be foodborne illnesses, but the results all come back negative. We know all the students were confirmed to be immune to hepatitis B before enrollment at Kodiak College, and hepatitis C isn't foodborne. Neither are yellow fever, dengue, West Nile virus, Rift Valley fever, chikungunya, which all also could cause these symptoms. We could try to culture the food to try to grow the agent, But that isn't always effective because some pathogens won't grow in food without being in a live host. So we look at the timing of symptom onset the Epi curve provides to help narrow down what the agent may be. We also consider environmental and host factors. Think about what agents are endemic to Kodiak Island. Could college students be higher risk for any infection that could be causing this outbreak? Were the roommates of ill students affected, or only the individuals who ate at the restaurant? To recap, we have 60 ill students, 56 of whom ate a burrito. 150 burritos were served during the time frame of the outbreak. And of 850 students who did not eat a burrito, 4 are ill. So if we wanted to calculate the attack rate for a burrito overall rather than for specific ingredients, we would divide the 56 students who ate a burrito who got sick by the total students who ate a burrito to get an attack rate of 37%. Relative risk can be calculated by dividing the risk of disease among those exposed by the risk of disease among the unexposed. If a relative risk is greater than 1, that means the risk of disease is increased by the exposure. A relative risk equal to 1 means the exposure does not affect the risk of disease. And a relative risk less than 1 means the risk of disease is decreased by the exposure. To find the relative risk of a burrito overall, we divide the burrito attack rate we got previously by the risk of disease among those unexposed. So who didn't eat a burrito? We know there's 1,000 students at the college and 150 ate a burrito, so we can subtract 150 from 1,000 to get the students who did not eat a burrito. And there's 4 people who got sick even though they didn't eat a burrito. To calculate the relative risk for exposure to each specific burrito ingredient, we divide the attack rate for those exposed to that food by the attack rate for those not exposed to that food. For rice, we would divide 48 by 12 to get a relative risk of 4. To determine if a food was independently associated with disease, you calculate the relative risk and compare it to the null value, which would be a relative risk of 1. Relative risk is a measure of excess risk. You can also think of it as the probability of illness in those with exposure divided by the probability of illness in those without exposure. Remember that risk refers to the probability of occurrence of an event or outcome. On a multiplicative or relative scale, the relative risk of 4 we got for rice means it increases the risk of disease by 300%. You subtract 1 to get how much that exposure changes risk. Eating black beans doesn't change a person's risk because the relative risk is equal to 1, the null value. Relative risk is only an estimate, and the hypothesis that the risk is different from 1, the null value, can be tested and is reported with a p-value and a 95% confidence interval. Those of you taking biostatistics are likely learning how to do this, and those of you going on to take more advanced epidemiology courses will learn how to use software like Stata, SAS, SPSS, or R for statistical analysis. For this principles course, the important thing is to know where relative risk comes from and how to interpret it. When we compare the relative risks of the various burrito ingredients, the maize tortilla stands out as being by far the furthest away from 1. After identifying maize tortilla as the primary factor associated with disease, you call the restaurant owner and ask about the tortillas. She says they were purchased at an amazing discount from a seller based in eastern Kenya. She's read about the terrible drought they've been enduring in Kenya, so she thought buying these tortillas would be a small way to help out while also saving the restaurant money. If maize is stored before fully dried, it may grow aspergillus, a fungus that produces aflatoxin. Farmers most often store maize before it's fully dry in situations of food shortage and extreme weather events, which prevent the traditional timing of farming practices. For example, early harvest or storing food in a house, which is more moist than other storage locations, can contribute to aspergillus growth. Circling back to the steps of an outbreak investigation, after we identify the causative agent, we would recommend or implement control measures. In this example, discarding the rest of the maize tortillas at the restaurant and not buying from the same supplier would probably be sufficient. For other outbreaks, control measures may include sanitizing equipment at food processing plants, providing bathrooms beside fields to prevent contamination of crops with farm workers' waste, or ensuring cooks wash their hands properly, depending on the outbreak. I shared a blog post I wrote about a hepatitis A outbreak when I was the clinic manager for a refugee camp clinic in Greece on the course Blackboard. In that outbreak, we cleaned all surfaces with bleach and administered vaccines as post-exposure prophylaxis to people at high risk of health complications if they were to get hepatitis A after everyone had been exposed. I got a group of Americans to join me in taking lead on the highest risk cleaning because we were all vaccinated for hepatitis A. Most of the medical volunteers were veterans, and we were all in high risk occupations in the US. But the Greeks and the Syrians weren't vaccinated. So even those who were young and healthy were higher risk if they were to get exposed. The final step in an outbreak investigation is to communicate findings. In this example, you would probably send an email to all students in Kodiak and encourage anyone else who is ill to seek care at the student health clinic. You would also communicate with the public health official for Kodiak. I'm pretty sure they just have one person out there, but in some jurisdictions you may have a city health department, county health department, and state health department that would all want to be kept up to date and may assist you with an outbreak investigation. Like relative risk, odds ratio is also a measure of excess risk. Odds refers to the probability of occurrence of an event divided by the probability of the event not occurring. For odds ratio, we're looking at the odds of aflatoxicosis in those exposed to a maize tortilla compared to the odds of aflatoxicosis in those who were not exposed. Take note of how this 2x2 table is set up. It's the same as in previous lectures. 150 is in the lower right corner because 150 burritos were served. And the disease column adds to 56, which is the number of people who were ill. And the people who are not ill who ate a burrito is 94. Remember, previously we subtracted 56 from 150 to find the people who were exposed but are not ill. And everyone who ate a burrito either ate a maize tortilla or a flour tortilla, so the exposed total of 55 and the unexposed total of 95 add up to 150. Even if you don't need the column totals for whatever you're using the 2x2 table for, it can be helpful to go ahead and add them for yourself as an extra check to make sure that you correctly put disease on the top and exposure on the left. This is especially important if you're using formulas like A, B, C, D with the cells of a 2x2 table, because if you accidentally set up your 2x2 table wrong, your calculations will be wrong. It's also really important to think through what it is that you're calculating and what it means. Plugging in numbers to formulas isn't going to really help you learn epidemiology. It's much more important to understand what the measure of risk means and how to apply that to the situation it's being used for. Even if you're not going to go on to do research yourself, it's very important when you're reading research articles to understand these concepts, because then you can critically appraise the method section and analysis done by others to better judge whether their conclusions make sense given their findings, or if their methods are questionable or conclusions couldn't have really been made given the data they actually analyzed. For the odds ratio in this example, we're going to divide the 50 people who are ill who ate a maize tortilla by the 5 people who ate a maize tortilla who are not ill, because that's the odds of disease in the exposed, which is everyone who ate a maize tortilla, divided by the 6 people who got sick but did not get exposed out of the 89 people who did not get exposed and are not sick, because that's the odds of disease in the unexposed. The measures of risk for this practice problem are way higher than most normal situations because I just completely made up the numbers, but I'm going to get to some with more realistic data later on. I think the odds ratio format with two fractions is helpful conceptually because it makes more sense, at least to me, to think of it being the disease in the exposed divided by those exposed who don't have disease, and the disease in the unexposed divided by the unexposed without disease. That makes sense. But a shorthand you can do is you can actually cross multiply to get the odds ratio. So that is quicker and perhaps easier in terms of the math, and you'll get the same answer. But it's important, rather than just randomly cross multiplying things, to think through what it is that you're calculating and why. Attributable risk is also known as risk difference. It's the risk in exposed minus the risk in the unexposed group. It's an estimate of the probability of disease in someone with the exposure minus the probability of disease in someone without the exposure. And it's usually expressed as a percentage. For this example, we're subtracting the 50 people who got aflatoxicosis who ate the maize tortilla out of all the people who ate a maize tortilla minus the people who got aflatoxicosis who did not eat a maize tortilla out of all the people who ate a burrito but did not eat a maize tortilla, our unexposed group. Again, note that the denominators are not the vertical column of those without the disease. They're the totals for the exposed and unexposed. From this, we can say that 84.7% of the risk of aflatoxicosis is attributable to the maize tortilla. We could also interpret this by saying eating a maize tortilla increases your risk of aflatoxicosis by 84.7%. The attributable risk, or excess risk, is what you're left with when you subtract the background risk. Remember that attributable risk is the proportion of disease incidence that can be attributed to a specific exposure. For attributable risk, you can think about it as subtracting the risk that is not the fault of the thing that we're talking about. Using overweight and obesity as an example, if we want to know what proportion of the risk is contributed by drinking sugar-sweetened beverages, we need to subtract the background risk for obesity to determine how much more risk obese people have who drink soda daily, for example. If we didn't subtract the risk we all have, we would erroneously overestimate the risk of obesity from drinking soda. I know there's a lot going on in this slide, but I wanted to summarize everything together in one place for you to make it easier to compare and see the differences between these different measures. We looked at attack rate to see the people with exposure to each burrito ingredient who got sick out of the total people with exposure to that burrito ingredient. Attack rate is used in outbreak investigations, and it's based on your case definition for that outbreak. Attack rate provides the numerator for relative risk, which is looking at the risk of disease among those exposed divided by the risk of disease among the unexposed. In epidemiology, relative risk is often used in randomized controlled trials. Odds ratio is similar to relative risk, but it's looking at the odds of disease in exposed divided by the odds of disease in the unexposed. The interpretation of odds ratio is almost the same as relative risk, but the key difference is it's the odds for odds ratio rather than the risk for relative risk. Odds ratio can provide an estimate of risk, which is helpful for rare events. In epidemiology, odds ratio is often used in case control studies. For odds ratio, a rule of thumb is that it will usually provide a good estimate of risk when the probability of the event is less than 10%. The odds ratio will approximate relative risk for rare events. When there's no association between an exposure and the outcome, the odds ratio and relative risk are the same and should both be 1. When there's an association between exposure and outcome, the odds ratio exaggerates the estimate of their relationship. The odds ratio will get further away from 1 compared to the relative risk. But the odds ratio tends to exaggerate the difference compared to the relative risk in either direction, especially as events become more common. You may be left wondering why anyone would use odds ratio since it's less accurate than relative risk. We need to use odds ratios sometimes because we need to know the population at risk to include it in the denominator to calculate risk. But sometimes we can't know how many people in the population were exposed. For example, if we're doing a retrospective case control study where the cases are people with thyroid cancer and the controls are people without thyroid cancer, we likely wouldn't be able to figure out which of the people with thyroid cancer had been exposed to Roundup in their lifetime, for example. In that study, relative risk couldn't be calculated, but odds ratio could be used as a measure of the strength of association between Roundup exposure and the outcome, thyroid cancer. Hazard ratio uses a test statistic such as the Cox model. I mentioned some of you may be doing this in biostatistics, or if you take more advanced epidemiology courses, you'll learn how to use software for statistical analyses. A hazard ratio tells us the probability of the difference being due to chance. It's reported with a 95% confidence interval, and a p-value less than 0.05 is considered significant. If the hazard ratio is not equal to 1, that means there's a difference in hazard between the groups. But it's not directional, so it doesn't tell you whether the factor increases or decreases the hazard. Hazard ratio is similar to odds ratio, but it's not for a specified unit of time. It's a cumulative summary statistic for the whole study. I explained standardized mortality ratio when talking about measures of morbidity and mortality and survival analysis in class 1. Hazard ratios, also known as mortality rate ratios, are the chance of an event occurring in the treatment arm divided by the chance of the event occurring in the control arm. Hazard ratio is like the odds ratio, but instead of being for a specified time period, it's the chance of the outcome over the entire course of a study. Remember that Kaplan-Meier curves have to be interpreted in their entirety. You can't just pick one point on the case or control group's line to determine the chance of the outcome in that group at that particular time. A hazard ratio represents the difference between the two lines on a Kaplan-Meier curve. Attributable risk subtracts the risk in those with the exposure from the risk in those without the exposure to eliminate the background risk. Think about the diagram on the previous slide. Another example, all Americans have some risk of frostbite. Frostbite could happen to anyone, but living in Alaska probably increases our risk of frostbite significantly compared to the general US population. If we subtract the risk of frostbite for the general US population from the risk of frostbite for the Alaska population, that would give us the attributable risk of frostbite. How much of the frostbite can we blame on living in Alaska? The exposure in this example. We could also determine the proportion of risk, the incidence, attributable to the exposure by subtracting the incidence of frostbite in Alaska from the incidence in the US population, then dividing by the incidence in the total population. An attributable risk of 0 means there's no difference in risk between the exposed and unexposed groups. Let's compare relative risk and odds ratio. We research whether drinking water source is associated with thyroid cancer in a farming community where Roundup and other herbicides have been detected in groundwater. On the left, we have 3 samples, each consisting of an exposed group and an unexposed group. You can see the data for the control group labeled municipal water repeats 3 times. It's the same data all 3 times. But if you look at the groundwater exposed groups, you'll see as the incidence of thyroid cancer increases, the odds of thyroid cancer increases from 0.11 to 0.43 to 0.82. And using that data, the odds ratio goes from 1 to 3.9 to 7.45. But the relative risk using that same exact data goes from 1 to 3 to 4.5. Note that when calculating relative risk, the total population at risk was used in the denominator, whereas when calculating odds, only those without the disease are in the denominator, not the total population. Relative risk and odds ratio can both provide helpful information, but they're showing us something slightly different. And they're not interchangeable, although sometimes more than one measure of risk is used together to provide a fuller picture of what's going on. This example shows when the rate of disease in the sample of people exposed increases, the odds ratio exaggerates the difference between the exposed group and the control group more than the relative risk does. The relative risk and odds ratio were the same when the incidence of thyroid cancer was low, but they got further and further apart as the incidence increased in the exposed group. Let's look at how relative risk and odds ratio differ when used for a rare disease compared to a really common one. For the thyroid cancer study, we calculate relative risk by dividing the 200 people exposed to Roundup in their drinking water who got thyroid cancer by the 10,000 people exposed to Roundup in their drinking water, by the 100 people who got thyroid cancer but did not have the exposure, out of the 10,000 people who did not have the exposure, which gives us a relative risk of 2. For the obesity study, we divide the 5,000 people who are overweight or obese who drink sugar-sweetened beverages by the 10,000 people who drink sugar-sweetened beverages, divided by the 2,500 people who are overweight or obese who don't drink sugar-sweetened beverages out of the 10,000 people who don't drink sugar-sweetened beverages, which also gives us a relative risk of 2. The people exposed to Roundup in their drinking water were 2 times more likely to get thyroid cancer than the people without the exposure, and the people who drank sugar-sweetened beverages were 2 times more likely to become overweight or obese compared to those without the exposure. For the odds ratio of the thyroid cancer study, we would multiply the 200 people who got thyroid cancer who were exposed to Roundup by those who were not exposed and did not get cancer, divided by those who got cancer but were not exposed, multiplied by those with the exposure who did not get cancer. Here I'm using the cross multiplication format because it's quicker rather than the fraction format, which is more logical. That gives us an odds ratio of 2.02, so it's almost the same as the relative risk for the thyroid cancer study. For the obesity study, we multiply the 5,000 people with the exposure who are overweight or obese by the 7,500 people without exposure to sugar-sweetened beverages who are not overweight, divided by the 2,500 people without the exposure who are overweight or obese, times the 5,000 people with the exposure who are not overweight or obese, to get an odds ratio of 3. Because obesity is common, the odds ratio exaggerates the difference between the groups. In this example, obesity is so common that odds ratio no longer provides a good estimate of the relative risk. Let's revisit the scenario of a multi-drug resistant E. coli outbreak linked to beef from Colorado used in a previous class. What would you expect the epidemiologic curve to look like for that outbreak? Because this example sounds like a single shipment of meat was contaminated, it likely would look like a single exposure, but because this bacteria can also spread person to person or via contaminated surfaces, I'd expect to see more irregular spikes than a classic single exposure. For example, if one person in a household eats a hamburger at a cookout, then goes home and doesn't thoroughly clean their diarrhea from bathroom surfaces, family members could become infected even though they didn't eat the source food. This would cause a little spike on the line delayed in time, since their exposure would only take place after the initial index case and their household became ill. But overall, it would likely appear most similar to the single exposure curve. Alaskapox is an orthopox virus, which is a double-stranded DNA virus. It was discovered in 2015 near Fairbanks. The first known fatality from Alaskapox just occurred in January of 2024. The 6 prior known cases all caused a local rash with lymphadenopathy and didn't require treatment. Given this information, what is the case fatality rate of Alaskapox? Remember, case fatality rate is the proportion of people who die from a specified disease among all individuals diagnosed with the disease over a certain period of time. This calculation differs from that used for mortality rate because while the number of deaths serves as the numerator for both, mortality rate has the whole population at risk in the denominator. But case fatality rate uses the people with that disease in the denominator. The Alaskapox case fatality rate currently would be that one person who died of Alaskapox divided by the 7 people who have gotten Alaskapox to get 14.3%. Clinicians in Alaska are encouraged to promptly report suspected cases of Alaskapox by calling the Alaska section of Epidemiology so public health staff can facilitate testing. Would this be classified as passive or active surveillance? This would be an example of passive surveillance because the clinicians are taking the initiative to report suspected cases. The public health agency isn't actively making sure that they collect data on all the cases that occur. A passive system like this can miss some cases, but an active system is often very expensive, and for a rare condition like Alaskapox, the cost of an active surveillance system likely wouldn't be justified because of the number of public health agency staff required to make sure that they collect data on every single case that has occurred within the state, because so few cases of Alaskapox actually have occurred. Alaskapox has been detected in small mammals such as red-backed voles, and most human cases have been linked to contact with rodents or a cat with rodent contact. Which role in the epidemiologic triangle do red-backed voles likely play in the transmission of Alaskapox if cat scratches are the primary means of human infection? Agent, vector, host, or reservoir? Reservoir is probably the best answer. The vole may be a reservoir host of Alaskapox virus. The virus would be the agent, and the cat would be the vector in this example, if we're going to label the human as the host, even though the human may be only an incidental host. We don't know enough about Alaskapox yet to know for sure, but based on the information we do have, it seems like the vole is the reservoir and the human is an incidental host. So the cat would be a vector when it spreads the agent from the reservoir to the host. Remember that the definition of a vector is any living thing that carries or transmits an infectious pathogen, such as a parasite or a microbe, to another living organism. Let's say 6 of the 7 people who have contracted Alaskapox were exposed to small mammals, such as voles, or a cat that had been hunting small mammals, but one person who became infected had no such exposures. Fairbanks and the Kenai Peninsula have a combined population of about 92,000 people, and 20,000 of those have a cat or have had direct contact with small mammals. What is the relative risk of Alaskapox in the combined population of Fairbanks and the Kenai Peninsula? Relative risk is the incidence rate among the exposed group divided by the incidence rate among the unexposed group. So we would divide the 6 people with the exposure who got Alaskapox by the 20,000 people with the exposure, divided by that one person who got Alaskapox even though they had no exposure, divided by the unexposed population, which we find by subtracting the exposed from the total population, which gives us a relative risk of 22, rounded to the nearest whole number. So the relative risk of Alaskapox is 22 times higher among people exposed to a cat or small mammals in Fairbanks or the Kenai Peninsula compared to the general population there. What's the attributable risk of Alaskapox from vole or cat exposure in the combined population of Fairbanks and the Kenai Peninsula? For attributable risk, we subtract the 6 people with the exposure who got the disease out of the 20,000 people with the exposure, minus the one person who got the disease but didn't have the exposure out of the total population without the exposure, which gives us an attributable risk of 0.00139%. That means that on an additive scale, if you live in Fairbanks or the Kenai Peninsula, being exposed to a cat or voles increases your risk of Alaskapox by 0.00139%. This is close to zero. If it were 0, that would mean that there's no additional risk for those with the exposure. But because this is a very rare disease, but a lot of people interact with cats or rodents, the attributable risk is very small. This is another example where you can see there can be a dramatic difference between these different measures of association depending on how common or rare a disease is. This doesn't mean we can't blame cats and rodents for infecting people with Alaskapox, but because it's so rare, everybody who interacts with cats and rodents still has a very, very small risk of actually getting Alaskapox. Let's revisit the example of sugar sweetened beverages and the risk of overweight and obesity. For attributable risk, we divide the 5,000 people who drink sugar sweetened beverages and are overweight or obese by the 10,000 people with the exposure and subtract the 2,500 people who are overweight or obese without exposure to sugar sweetened beverages out of the 10,000 people without the exposure, which gives us an attributable risk of 25%. On an additive scale, being exposed to sugar sweetened beverages increases your risk of being overweight or obese by 25%. Now let's look at the relative risk calculated for this example previously. Remember, relative risk is the probability of disease given that someone was exposed relative to the probability of disease given that someone was not exposed. In this example, someone who is exposed to sugar sweetened beverages is twice as likely to become overweight or obese. See how if you compare the risk of obesity in the unexposed, 0.25, to the risk of obesity in the exposed, 0.5, the risk in the exposed group is twice that of the unexposed group. Bringing in the odds ratio too, which is the odds of disease in the exposed group divided by the odds of disease in the unexposed group, which gives us an odds ratio of 3, we can say the odds of obesity for someone who is exposed to sugar-sweetened beverages is 3 times the odds for someone who is not exposed. We can subtract 1 from the odds ratio to say that the odds of obesity for someone exposed increases by 200%. In summary, this class introduced and compared ways of measuring the risk of disease using epidemiologic data. You can see from these 3 examples that risk and odds are related but not interchangeable. To recap, we talked about communicable disease transmission, the epidemiologic triangle, epidemic curves, and went through an example of an outbreak investigation, including how to calculate and interpret an odds ratio.